Hi, I'm Dr. Angela Yakey.
And I'm Dr. Kathleen O'Neill Smith.
Welcome back to the FIRRIMup Doctors, Good Medicine docu-series.
We are so glad you joined us.
We want to provide you with credible health resources, guide you in your treatment options, and fire you up to take control of your health.
Hello and happy Thursday, everyone. Welcome back to your FIRRIMup Doctors webinar. We are so happy to have you, especially for our last webinar for the next 2 weeks. Today, we're going to be doing a special COVID Q&A where Dr. Akey and Dr. Kathleen will try and answer as many questions as possible to the best of their knowledge on the vaccines currently available. And now I will go ahead and introduce both of your wonderful doctors.
Hi, Emily. Thank you for the introduction. Hi, Dr. Kathleen in Boston. I hear it's snowing up there.
Woohoo, we have about 20 inches. I haven't even shoveled, so I'm not going anywhere for at least 24 more hours.
Oh, good. We could continue to take the deep dive into the science of the COVID vaccine.
Gosh, no, I'm totally into it. Let's go. Happy December 2020, and let's get to January 2021. Let's go.
So welcome, everybody. Welcome back to the FIRRIMup Doctors webinar. There is hope on the horizon here. So we're excited after 10 months to be able to kind of sift through all the questions that you sent in. And you could continue, if you're on the Zoom, to continue to, we'll watch a chat through Emily. Next slide, Emily. So yeah, Merry Christmas, happy Hanukkah, Kwanzaa, whatever you're celebrating, just be happy. We're almost to the end of the 10 months of some serious hardship, right?
Oh, it's craziness. It's craziness. But excited to be here to answer questions. We've put out a lot of information. Some things have changed over time, but very little. And we want to just be really clear and with you all about what we know, what we don't know, debunk the myths, answer your questions, and have you go sail through the next couple of weeks with more confidence that 2021 will be a better year.
Yeah, and we actually have a Christmas present for you all, compliments of Audible. So basically our Kick COVID-19 to the Curb audiobook, which was read by me and Dr. Kathleen, plus my son Timothy was a narrator, and one of my interns, the Cabbage Patch Kid, Reshma, who's now in PA school, was a reader. It actually got published on Audible about 48 hours ago. And they said that we can actually give you a free copy if you're not already an Audible member. And if you're an Audible member, it's 1 token. So if you're interested in getting a free copy of the book Kick COVID-19 to the Curb, just email in to that email, firrimupdoctors@gmail.com, and we will send you the 3-hour and 40-minute audiobook illustrated with symphonic music. And we try to illustrate it to really hone in on the castle analogy and the chess set analogy to your immune system. And now more than ever, you need to understand your immune system when we're talking about vaccines. So Merry Christmas, everybody.
I know, it's really good, actually. I listened to a lot of it, and wait a second, Emily, thank you so much for just shifting around these slides the way you do and being so amazing. We've been so lucky to have you. So I just want to, it all feels like magic when you're doing it. So thank you for being there and doing that fantastic work always.
I have to say, Emily is an example of the Cabbage Patch Kids, the interns that really have been able to produce the material. Like Dr. Kathleen and I think, these books, these 40 webinars and all of this messaging, Facebook Live, social media, it's the interns.
Just
so thank you all.
This woman over time, this woman, Emily, down below, because she's going to be famous. And I'm excited to cheer her on and be one of her best cheerleaders. She's amazing.
Thank you.
Thank you, Emily.
Of course.
So then then in January, we're going to talk about optimizing your body composition, but always we'll end with a COVID update. Next slide.
Well, I think one of the key things about these slides, if we go back one slide, is really to let you guys know, the goal isn't to give you, what Dr. Akey and I do is personalize individual medicine attention based on the fact that all of you are biochemically individual. You are not like your twin sister, even if you're an identical twin, or your twin brother if you're an identical twin. I have identical twins, and I know that for a fact. So I think it's important that you understand we're giving you general information. And if you need a personalized approach, we're happy to help you. You can sign up for telehealth visits with us, but you should really know that in the age of 2020 and 2021, we are now have a full understanding, regardless of what you're addressing in your health or sickness repertoire, of personalized, individualized medicine. And it is very specific to an individual, what the needs are, what's going to help, what's not going to help. So we're giving you the general understanding of how important things are and what to be looking out for, so that you can have conversations either with your doctor, maybe they understand, maybe they don't, or find a doctor who does.
It's a good point. Okay, so what should I eat to strengthen my immune system? Is there a certain diet, Dr. Kathleen?
There's no one diet for anybody. There is no one diet. I studied physiology, I studied nutrition, I have degrees prior to medical school, and I used to think that everybody should eat the same diet. There's no one diet for everybody, because ketogenic can be good for one type of person and it can be really dangerous for another. I'm the kind of person, I eat ketogenic. What happens to me, Dr. Akey? I'm in an ICU, right? And
Right.
before I get to the ICU, I think I'm going to die, and I could die. So ketogenic, or whatever the diet is, really whatever diet. There is no certain diet. You can look up, what do we look up? Anti-inflammatory diets, ketogenic diets, paleo diets, autoimmune diets, the autoimmune protocol. There are all kinds of diets out there. You can do process of elimination by trying these diets, by mixing and matching. Dr. Quebeca does keto green. Everybody has their own diet that they like to promote. The reality is, whatever you do, there should be green. It should be green. So that's for sure, because green is live. And if you want a live body, you need live food. That's it. That's for sure. But beyond that, whether it's keto green, whether it's paleo green, whether it's whatever, it's going to be more specific to you for sure. MCTs are wonderful, but are they good for everybody? No, I don't do well with MCTs either. So some people do, some people don't. Trust your body, try things out, find out what will help. We know that intermittent fasting absolutely gives the body a rest, a break. So intermittent fasting, a minimum of 8 hours, is really a good idea, because you let the inflammatory process, which is normal after eating food and during digestion, that normal process has to resolve before we hit it again. So intermittent fasting is fabulous. Is it the be all and end all and the only thing? No, but it's very, very good. Fruits and vegetables, again, they're live. You put live things into your live body, guess what you get? Life. You put dead things into your live body, guess what you get? Death and rot, R-O-T. So you choose, and you look at the magnitude. Dr. Akey always laughs at me when I'm on a roll, and I happen to be on a roll.
Well, I would say, though, that with 6 out of 10 Americans having metabolic syndrome, prediabetes, I think especially during this pandemic, you want your insulin level low. So maybe not
100%.
necessarily a ketogenic diet, but low carb, low insulin, because insulin is inflammatory. And if you look at the morbidity and mortality of COVID-19, it's obese, it's diabetics, it's metabolic, and we just want to make sure you're not inflamed going into it.
Insulin is only good when you need to put on fat to keep yourself insulated and protected against famine. But beyond that, the insulin is not, too much insulin is never going to benefit you, and it will always come from excess carbs or processed foods or foods that are refined. This means they're not live anymore. Foods that are refined, foods that have been touched by man made it, don't eat it. The longer the shelf life, the shorter your life, your healthy life. So, anything like that will definitely contribute to dysinsulinemia and insulin resistance and inflammation. So for sure.
And there's different theories. Remember that There's 4 phases to this COVID disease, and phase 3 is where the lung gets involved and it gets inflamed. You don't want to go into it inflamed. And there's different theories as to why belly fat or adiposity, visceral adiposity or fat around the waist causes inflammation. I know that one of them is like the fat cells kind of causes ischemia or low blood flow. And so the tissue gets poorly perfused and you have elevated fire or inflammation. We check HSCRP, for example, in your blood, and we'll tell you you're a little inflamed. And we'll say take fish oils or cut down the insulin, fast, etc. What are the other reasons why belly fat and visceral adiposity cause inflammation that you've heard, Dr. Kathleen? Why are obese people inflamed?
So, effectively fat cells, adipocytes, wherever they are, they're different kinds. So fat, even though not calorically active, is very bioactive, right? Fat is not calorically active, meaning you don't burn a lot of calories having a lot of fat. You burn a lot more calories thermogenically having muscle, protein. So fat is thermogenically not that active, but bioactive. It has a lot of biological activity. And I believe that fat is, from a pragmatic perspective, not the science, but the fat is there because it's an attempt at storing stem cells and making stem cells available so that you can heal yourself. The problem is they're trapped. They can't get out, and they're trapped in that tissue because it's not very thermogenically active in terms of calories burned. So they're trapped in there. And then the other thing about adipocytes is that it is intended to insulate. There's a lot of different things about it, but the adipocytes insulate. They protect you if you have a physical injury, a mechanical injury. They basically are intended to, there's a lot of stem cells stored in fat. And basically, but we can't activate it. But remember also we had a conversation in a webinar, Dr. Akey, that was about what happens when there's inflammation or acute injury. We get infiltrated in any tissue with fat. And that is a response for healing, but it doesn't heal. It dupes you, and then you end up with that piece of meat. We've talked about this on this webinar, that's more fatty. And a fatty piece of meat is juicy, and a fatty piece of meat tastes good, but it's not life-giving. So we have to be aware of that. Those are excess fats. Those are inflammatory fats. Those are fats that are not metabolically active in terms of calorie utilizing. And those are fats that, because they're so trapped, you're going to put on more and more and more in order to attempt to heal you, but you're really never going to be healed. So does that answer the question?
Yeah, I was just thinking of my friend's significant other in South Florida. He's 54, was about 40 pounds overweight, got COVID around Thanksgiving. She was perfectly fine. She's slim, pretty fit. She never got even one symptom. He started coughing. By about 10 days ago, he couldn't breathe. She called me for help, but his oxygen was 90%. And when he moved, it dropped to the 80s. I said, to the emergency room right now. And so he gets admitted. He's in high level care on high flow oxygen, 5 days. So he got the treatments in the hospital, didn't get any better, didn't get any worse. So they discharged him home with very marginal, still 90%. Actually, this time when he walked to the bathroom, he'd desaturate to the 70s, and so borderline readmitting him about 4 days ago. So I offered some suggestions with her for some progressive therapy. So now, thank God, he's up to 93% and he's not desaturating. But the bottom line is, I think this may be an exaggeration, but she said since Thanksgiving, he's lost, she says about 40 pounds. I don't know that he actually got on a scale, but he's lost a significant amount of weight. And I just kept thinking that he went into this as a pre-diabetic obese man. That's the highest risk, right? Middle age, obesity, pre-diabetic, high insulin, inflamed already. And he almost didn't get out of it. And so, yeah, that's why I thought that we'd spend some time on really talking about obesity and metabolic derangement.
We'll talk more about body composition next month, but I think you're right about that. There's a couple comments on that I want to make. One is that's hospital-driven care. The fact that he didn't have a physician, a primary care like you, who's in the outpatient world that could have treated him appropriately, so he might have avoided that. I think prehab is better than rehab, meaning do something in advance rather than having to rehab and get better, as he's trying to do now. So I would say that that is extremely inappropriate and really is one of my major pet peeves in medicine, that we have big pharma, hospital-based care that, how do you say, pre-upped, or I don't know it. That's the way we practice, as opposed to doing prevention and prophylaxis, which I absolutely 100% believe in, restoring as much aberrant physiology, pathophysiology as early as we can to prevent stuff like that, because he is going to have residual no matter how you slice it. And the other thing about the weight loss, so he lost 40 pounds. I can assure you that the 40 pounds that he lost since Thanksgiving in less than a month is not fat tissue. I can assure you that it's muscle tissue. I can assure you that the catabolic effects of what he's experienced have to do with loss of muscle, which is not what he wants to lose. He wants to lose fat. So you can't lose muscle on a dime. You have to focus on what are you going to do to lose, I'm sorry, muscle or fat. But if you're sick and you lose weight, it's usually muscle that's gone, especially if you're a hospitalized based patient. I've been in that situation. I lost 40 pounds of muscle when I didn't need to. It's not healthy. That's called skinny fat. And I've been a skinny fat person.
Well, I'm glad you're healthy now. No, he actually, he got hospitalized and immobile because he couldn't breathe because he had no oxygen, no lung function, and was put on blood thinners. He's still on blood thinners because remember, COVID is a clotting disorder as well. Very marginal as early as Monday. So he's pulling out of that with some progressive treatments that we're going to use to design some of our clinical trials that we're working on for progressive therapy.
Mm-hmm.
But anyway, my point was, and this brings it home, another case this morning, I saw a post-COVID patient. She's a 66-year-old woman who's still working as an X-ray tech at the hospital. She got it in the hospital at 66. She didn't want to retire. But about 3 years ago, she was obese and out of shape with high cholesterol and high blood pressure. She decided to take her health seriously. So she got in shape, started bicycle riding and playing golf. So she got the COVID about a month ago, saw us, early symptoms, early intervention, and treatments, progressive therapies. She got to stay home. I left her home for, at the time, it was 14 days. Do you know, she told me today that she feels great. She has no symptoms. The classic post-COVID symptoms that we look for are brain fog, fatigue, inability to exercise, chest pain. She's biked 25 miles yesterday, no problem. In a month, she's 66 with hyperlipidemia, previous metabolic syndrome, was able to bike 25 miles a month after COVID, no symptoms. So that's the point. You want to prehab. You want to go into this fit and not inflamed and obese. Okay, next slide.
Well, here's the deal. I don't think, honestly, we're giving a lot of attention to COVID over the last 9 months, right? You and me, everybody, the news. The deal is this: COVID is like the flu, okay? It's going to come back every year. There are questions on vaccines. If you get a vaccine this year or 2 doses, you're going to probably need another vaccine, just like the flu next year. COVID should not be killing people, okay? Maybe if you're well and you don't know you have a clotting problem, maybe COVID could kill you, but COVID should not be killing people. The fact that COVID kills people and that people die from it has to do with the fact that we are not healthy. So I say, let's get our tush in gear and let's get healthy and let's prehab so that rehab isn't even an option. So if you don't prehab, you're going to have issues that no one's going to understand, that are going to take a long, long time to potentially heal, like your doctor friend's husband. And maybe they're going to get better and maybe they're not. We don't know. I would rather not find out. I would rather say, what can I do today, tomorrow, the rest of December 2020, and all of January 2021 and beyond? Each day, what little bit can I do that adds together cumulatively with everything else I do to make myself better, so that if I get COVID, it's not a problem.
Yeah, and when you listen to the audiobook or read Kick COVID-19 to the Curve, you'll hear about the analogy of fortifying your castle so that there's no cracks when the enemy attacks. So we hope you enjoy that audiobook. They say you shouldn't take the current COVID vaccine if you have allergic tendencies. Is this true? A lot of vaccines.
Can we not answer each individual question? Because I would like
Sure.
to go through the questions and look at all of the questions questions on the vaccine. And I would like to talk generally about what we know about the vaccine, because I think we don't want to give specific advice to an individual over this webinar. I don't think it's appropriate. I don't think it takes into account biochemical individuality, and we could misinform somebody. And I want to be very careful about the information that we share with you, generally speaking, of what we know about this vaccine versus giving you a specific indication that you have an allergy, don't get it, will there be warnings later? What do we think? We're still evaluating, Dr. Akey and I, with esteemed colleagues, what we understand about this vaccine, what questions we have to continue to ask about the vaccines that are available. How do we determine who gets them? We're still evaluating that. The jury's still out on that. But what we want to tell you is what we know. We want to debunk myths, but we don't want to answer an individual question because that's not the point. We aren't there yet to be able to say, this is for this person, this is not for that person. We're not there yet. We can tell you, and I can tell you from research that I've done, that the companies who have made these vaccines have not disclosed other parts that are in the vaccine. Is there aluminum? Is there formaldehyde? Is there mercury? What else is in these vaccines? I don't know. So we need to understand those things. So in terms of general allergies, whatever allergy, we don't really know. It needs to be disclosed to doctors for us to make those, to help you understand whether it's right for you or not. So that's really important at baseline. So we're still learning. So I would like to look through, these questions to kind of think about it, what you're wondering about, so we can answer in a very general way. Because I don't really think we know for longer than a very short time, months, whether or not this is effective or safe. I really don't think we know that because we're in it, we're living it. So we don't have that data, but we can tell you to the best of our ability what we do know today.
Yeah, to your point about the information is just rolling out now, just as simple as the Pfizer vaccine, which has an emergency use authorization as of last week, the UK prior. We just now recently this week got the information on how to handle the vaccine in terms of supply chain. And we don't even have Moderna's yet. And so everything is so really for us to tell you, we just don't want to lead you astray because a lot of this is unknown. Next slide.
Yeah, we're in the middle of it. And we want to be sure that we don't give you misinformation. So here's another question, the downside allergies, downside or risks, allergies, should you get the vaccine? Are there going to be new things? Next question, what's the next question? Just so we understand and we can, upper limit lymphedema, don't use that arm. Well, that's a problem. If we're sending out letters, then obviously we're still learning about this vaccine. I think that's really important to understand. And you're right. I've read that some people are having problems in their arm, their shoulder. I've talked to friends of mine who are at Columbia, New York City, who basically, are promoters of vaccine. They're physicians, older physicians, wise physicians. And basically they're like, people can get Bell's palsy. People can get frozen shoulder. People can get this. That's important. We really should know the risks of anything before we do it.
But in regards to this one anyway, you don't generally, if you have lymphedema, you actually use the other arm anyway with any shot, including flu or tetanus. You don't want to use the arm with lymphedema. So that protocol would apply to any vaccine. Next slide.
What's the science saying about people with autoimmune disease getting the vaccine? Is it recommended for front with multiple autoimmune? That's a very personal discussion that someone has to have with their doctor. And that doctor has to know you, and that doctor has to listen to you. They cannot bring their biases to the conversation without understanding the concerns and risks, potential risks, and efficacy have to be discussed with these individuals. If an individual has an autoimmune disease, no mRNA vaccine has ever been licensed for human use before, right? It's never happened. So there's a lot we don't know. It's a completely new type of vaccine. And, we really need to be thinking about that. when we're thinking about putting this into people. So there are not long-term studies on this. There are short-term studies on this. And we would, if we had categorized the people who have been part of the studies, who have received the vaccine, which there are tens of thousands, hundreds of thousands, I'm sure, in total, we need to look at the categories of people in order to understand how to answer a question like this. This is not like, hey, don't worry about it. This is not like, well, you're a frontline healthcare worker, you should get it regardless. It is really, really important to understand a lot more about it for this type of a question, and the allergy question, and the lymphedema question.
Yeah, so we're over 100,000, but I want to see 1 million. I want to look at what happens after 1 million, because then you're really moving into what's called phase 4 clinical trial, where it's out in the public. So we finished smaller phase 3s, but we'll be at 1 million within a month. So then we can see.
Yeah, well, and we also have to know, like, a long-term effect or side effect 2 years out, there's no way to know right now. Everybody is speculating. So I think that's really important to understand and to accept if you choose to get the vaccine.
So can you get an antibody test done before receiving vaccine? First of all, anybody could get an antibody test. If I think that the question I think this is asking, and I heard Dr. Fauci say in a town hall, was if you've had COVID and antibodies, do you still get a vaccine? And he actually said just probably, I think was what I heard. So again, this
You
is
get a vaccine, he said?
He said, yeah, probably. It was Washington, D.C. It's what I heard.
Okay.
Yeah.
Well,
So you don't
think
know, you don't know if the antibodies are neutralizing or not. But I think at this point, if you've had COVID and you had an antibody, I think I'd be waiting. What about you? But we'd have to
well,
watch.
I think, first of all, I think the questions to ask are, have you had COVID? So this antibody test comes to this question. Have you had COVID? What does it mean to have COVID? Does a positive test mean you have had COVID? No. Positive PCR does not mean you've had COVID. Okay. It only means that you've been exposed. A positive test and symptoms consistent with COVID mean you have COVID. And then antibodies, if you can document them, not a yes, no qualitative antibody test, a quantitative antibody test that demonstrates that you have IgG antibodies, that you've had IgM antibodies that have converted to IgG antibodies, and that you have adequate antibodies. That's what we have available to us today. So yes, a PCR test, positive or negative, but symptoms of COVID that are undisputable and were not due to the flu or some other problem, for sure. If you had a negative flu test, then you can assume you had COVID. Then you can get an antibody test that's quantitative, and that will give you a sense of how many antibodies do you have in relation to the timing of your illness. That's the important thing. Antibody tests should not be done until more than 3 weeks post an illness. Okay. Now, soon, my understanding from company is we're going to be able to measure neutralizing antibodies for patients. That's not available presently that I know of, but that's going to become available, and that will be another important thing. So if we were to measure somebody's hepatitis B vaccine, and we gave them hepatitis B vaccine, and then we measured their antibodies, we wouldn't give them another vaccine. So why would we give them a COVID vaccine? Especially given that we can keep people well, we can treat them preventatively, we can treat them prophylactically, we can treat them if they have acute disease, unlike your friend's husband who should have gotten treated when he had acute disease. And we can follow them and make them better over time. I think we have to take a pause and we have to understand, why would we give people who have antibodies a vaccine?
So let me just reel it back. The discussion was, if you had COVID, would you still get a vaccine? And it wasn't necessarily about the antibodies. I think he was saying you might still consider getting the vaccine. So I think it's back to the individual discussion. So I just want to correct myself.
I think we need to be really clear, though, regardless of Fauci, because I would tell you, I've really thought about this long and hard, and I'm not going to get into big detail on it, but I feel extremely disappointed with every bit of information that's been available, because very few people have talked about, very few MD, PhD, doctor, clinician has gone to the literature to use the understanding of what they've learned through medical school and residency to talk, and we've talked about this, Dr. Akey, to talk about how to treat this. We've all talked with fear about test, but what do the tests mean? When do you know you have an infection? It's not the test that tells you you have an infection. It's how you feel that tells you that you have an infection. And the fact that it's not something else, even if the test is negative, it's likely COVID. So I think we have a lot of misunderstanding out there. I do not think we've done a good job as clinicians, physicians, educators in the media, educating people about how not to have fear, about how to prehab so they don't have to rehab, about how to be well. I think we've tried. You and I don't know that we've done the best job, but we could probably always do better. I'm willing to take that on. But the reality is that I don't think people even understand the basics. So getting an antibody test makes sense before you receive a vaccine. If you have antibodies that are quantitatively there, I would suggest thinking, have I had an infection with COVID? Yes. I have antibodies. Yes. Am I going to get a vaccine? No. That's logic to me. Complete and utter logic. If you have not been infected that you know of, you have not been sick with COVID, and you have antibodies, I would think twice. Do I want a vaccine? Do I not want a vaccine? You might ask different questions. So that's a different scenario.
Getting back to your, we're having so many mixed messages based on states too. Like even the fact of wearing a mask. Why aren't we agreeing to wear a mask? Even within my own household, there's even within my own household, because we're hearing so many messages from all over. We're just hoping that we're consistent as far as we can be consistent with a moving target.
That's correct.
So if you all are interested, if you've had COVID and you want quantitative antibody tests and you're within NFIM or in Treat Wellness in Boston, then just reach out to us and we'll get quantified IgG, IgM antibody tests, and we'll give you a one-on-one decision with that.
And as soon as the neutralizing antibodies come out, we know they're on their way. We know we're going to know where to get them. We'll be the first to have them.
Yes, realize, again, back to one of our first webinars, neutralizing antibodies neutralize the virus, and that's protective. Mm-hmm. The other thing, Dr. Kathleen, is I don't think we're clear on how high the titer has to be protective. So if I had a patient with COVID and I send quantitative, measure the IgG, at what threshold is it protective of that person?
Well, I think that's a moot point. And we've talked about this too. I think that we're assuming simple-mindedly, that it's only antibodies that treat and that act during an infection, an active infection and post an infection when there's cleanup to be done. It's not only antibodies. That's just so simple-minded. We also have T cells. We have all kinds of immune system cells that I think it's really important to understand. So we could measure a lot of things in people, including your doctor friend's husband, to understand what put him at risk. We could measure his T cells. We could measure his cytokines. We could measure his antibodies. We could measure a lot of things to see whether he's IgG, IgM, IgA, yada, 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 available. We should be doing some of that. So, and the reality is that it is more, getting sick with COVID and not recovering readily from COVID has more to do with other things than just antibodies. So I don't think we have to really get into that. The question is, even if you had it, you may have missed the window of opportunity to find antibodies in your system having been sick with COVID, but it's still likely, in my belief system, that you will be able to mount an antibody response, that you will not be a likely favorable host for a COVID bug if you've been infected with COVID, unless things change dramatically and you are immunodeficient for other reasons. You have cancer, you have something else. So I don't know if that's clear. I hope that's clear, but I think that this is obviously complex. I think it's a crapshoot out there with tests available at your local pharmacy, with tests available from, the local restaurant of whatever, I don't know, type of food you like. I just think this is horrid. And I do think that we should own it as physicians and clinicians, and we should set the record straight, debunk the myths, and make informed decisions on an individual basis with patients.
100%. And as a clinician doctor, I have patients I'm filling out a FMLA form on a woman who I've cared for 15 years, who never missed a day of work, who, when I saw her in telehealth, she's a healthcare worker. I said, you have COVID. Her tests were all negative. This is the summer. Her tests were all negative. Her antibodies were negative, but yet her lung function was horrible and she couldn't function. She had classic post-COVID symptoms: brain fog, can't exercise, chest pain, like chronic fatigue. I'm filling out a family medical leave act because I know this woman for 15 years that
She has COVID.
she has COVID, but none of her data is supporting COVID. So when I'm done with this call, I'm going to have to work with her disability people. There's no reason for her to malinger or anything else. She has COVID. And she's one of 3 that have post-COVID syndrome with no documented COVID. So getting to your point about really understanding testing. Well, as a clinician, even if all the tests are negative, I see you have a fever, can't smell, can't taste, can't breathe. I don't care what your tests are showing. You have COVID.
Agreed.
And post-COVID.
I have the same situation in my practice. It's really important to understand that. We have to use logic. We have to use physiologic. We have to understand. And of course, we want to rule out other things like flu or whatever it is. But the testing back in July and back in April, when some of my patients got sick in March in the Northeast, I mean, I think that the testing was horrific. The whole situation was, the timing was off. If you do a PCR test outside of a window of time, it's irrelevant. So I do think that it's really important that we take a step back, we go to 50,000 feet, and we look down at the lay of the land and the mess that's been made, and we clean it up, and we understand what we really understand now, which is, if it looks like COVID, smells like COVID, sounds like COVID, feels like COVID, but the test says no, it's still COVID.
Yeah, so I put on there post-COVID syndrome. I mean, I don't know what else to say, but and I even have a relative like that. So I do believe that even without data, with clinically, if you have you had those symptoms and you feel lousy after, it's COVID, post-COVID. Okay, this is talking about herd immunity, right?
Yep.
Will the vaccine help us to gather? Will it increase herd immunity? I think that's the purpose of having a vaccine. Now, as to when that happens, you still have to practice good hygiene, et cetera. Certainly not, it won't change anything, even if you got a vaccine. One of my Cabbage Patch Kids is a healthcare professional and got the Pfizer vaccine yesterday. She'll get number 2 in 21 days. But even so, nobody, around her environment, nobody really has had the vaccine. And number 2, I don't really know. I don't know if you know, Dr. Kathleen, when she will have been spiking her antibodies and to what level of protection. I know they're quoting 95% efficacy, but that's a vaccine protocol is time 0 and time 21 days.
Well, I would answer this question differently. I would say that we're already approaching, we're not at herd immunity, but that's the direction we're going in, especially in Florida. I mean, I think Floridians have chosen herd immunity in general. It's not a judgment. I think in the Northeast, we absolutely are like painfully back at phase 1. So I think for better or worse, I don't think there's one better, there's one worse, but I think that the entire country is definitely going in the direction of herd immunity. I also believe that the death rate from COVID is faster, compared to the spring and different points in July, is now approaching the death rate of the flu. So I think that that's true. And I think that we are approaching herd immunity. The people who generally are succumbing, sadly, to COVID are people who are immunodeficient or immunosenescent. It's the same difference to me, immunodeficient or immunosenescent. So those people would succumb to the flu. They would succumb to any other thing, especially if we didn't offer prophylaxis or treatment. So because we're not doing those things right at the day of illness or prior to being exposed, what do we expect? I mean, I don't know what to say. So I think that herd immunity is in the making. I think I don't know the details on this, but my understanding from MD PhDs and MD MPHs that I've read and listened to and spoken to is that if you get the vaccine, you can still transmit the virus. So you can get the flu vaccine and you can transmit the virus in your nasal passages. right? You don't get infected with it, but you can still transmit it. My understanding is that if you get flu vaccine and you get very sick with the flu, that you're not a great host for the flu to live in your nasal passages because you're ready to kill it with your own immune protection. So you're less likely to transmit it. So my understanding with the COVID vaccine is that if you get it and develop appropriate immunity based on the vaccine, that you still can transmit it. So it doesn't relieve you from wearing a mask. It doesn't relieve you from social distancing. It doesn't make you feel better about visiting with your elderly friend, parent, whatever, who may not have gotten the vaccine. It doesn't relieve you from potentially transmitting it to somebody somewhere who could be immunodeficient. That's my understanding.
Yeah, I agree. And then immunodeficient if means not enough of your immune system army are not working well. And then immunosenescent meaning your army's older, i.e. for humans, if you're over 40 years old, your immune system's older.
It's the same result in the end, senescence and deficiency. So just remember that you want the best immune system you can, a resilient, optimized, healthy immune system. I hope we're answering questions.
Well, a lot of these are still wait and see because it's so new. I mean, this vaccine was developed and released in 8 months. The prior vaccine that was truly FDA approved took 8 years. So
what are you going to do, Dr. Akey? Are you going to get the vaccine? I'm going to put you right on the spot.
you should ask me after Monday. I've arranged a call for me, you, and MD PhD from Yale, from UF, from University of California, San Diego, from
Clinic.
Columbia, Mayo Clinic. I have,
you.
and my brother, who's an MD PhD. But anyway, a bunch of smart doctor researchers, and then a basic science NIH retired scientist. Ask me Tuesday whether or not if you give me a Pfizer vaccine.
You know what, guys? We won't be here on Tuesday. I'm sorry.
If you're my patient, I'm offering an individual telehealth with me, and I will be much more aware after Monday, and then also group medical visit on 12/29 Tuesday from 3 to 4 p.m. So if you're high risk and my patient, you would qualify for group medical visit. What about you, Dr. Kathleen?
Well, if I had never had COVID, would I get this vaccine? I'm an autoimmune patient with a lot of autoimmune problems, and some heart disease and other disease in my family that's not your classic. So I would think long and hard personally about getting the vaccine before I understand A, the efficacy, and B, the potential adverse effects long term. So I am not afraid of getting COVID because I believe with my entire being, heart and soul, that we can prehab. Not only can we prehab, and I'm a believer, and this is my belief based on my knowledge, that we can prehab, so prevent, that we can prophylax, and that we can treat at the first day of acute symptoms. And I believe that 99.99% of people will get better. And those people who have the worst immunosenescence or immunodeficiency than we didn't understand or know about, or maybe a clotting problem that we didn't know about, that I try to measure those things. So I like to try to know, but there are things we don't know, that those will be the people that unfortunately will have challenges. But that will become clear during the course of their illness within 2 to 3 days. I would treat for that as well with anti-clotting mechanisms that are advanced. So I really believe that we can treat this. I think we can treat it and beat it. I think we stay positive and test negative whenever possible. But if we test positive, we stay positive and we treat immediately. And I believe in preparedness. And so I think that you need an appointment with your physician, with your clinician, and you need to know individually for you what you need to do. So I don't take vaccines for things that I want to give up responsibility for. I think I want to take responsibility for how healthy I am. I want to take responsibility for how I treat myself. It's a very individual question, but for me, that's how I feel. I believe no matter how sick I've been in my life, which has been very sick, I believe I will beat COVID. Maybe I'm false, but probably not.
I think that if you asked me in March, I think that we were all terrified, but having managed
Mhm.
COVID, treated COVID, gotten people out of the ICU and they're getting better,
Mhm.
seeing post COVID, I'm not scared of COVID. I want to be smart for our patients to prehab and make sure you're on the right supplements. I want our patients to notify us right away because we're following the iMask Plus protocol. If you don't know what I'm talking about, watch the webinar that we did here by Dr. Paul Merrick's group on December 3rd on the FIRRIMup doctors. It's and actually the now FDA, thanks to Dr. Corey's passionate plea in the Senate on December 8th, is reviewing ivermectin for early treatments, antiviral and anti-inflammatory. We've used it a lot with really good success, but we do a lot of other things. So I don't know if it was the ivermectin plus everything else or what one thing, but we've only lost one patient, and she was in her late 80s with interstitial pulmonary fibrosis going into
Wow,
COVID.
that's tough. Yeah.
But we haven't lost anybody else, knock wood. And I'm really, really proud of this effort and our team specifically, because I'm really glad that we haven't lost anybody.
Well,
So
I mean, when people come to us, they come to us with conditions. So we can only be as good as the patient wants to be to themselves. So if the patient wants help, I'll work 24/7, 365 to help them, but they have to do the job. So, and the sooner you come and the sooner you take care of it, even I'm talking at 15 years old, the better. So I really believe that we can only do the best we can with what we're dealt. And if we have interstitial pulmonary, I've been a geriatrician for a decade, but if we have interstitial pulmonary fibrosis, there should have been other things we were doing. Very aggressive prehab, very aggressive prevention in that patient. And it's really unfortunate for anyone to go, but those things are out of our hands, sadly. Mm-hmm.
So travel, I think also you could look at the cdc.gov website about travel. In general, though, they say that in JAMA, Journal of the American Medical Association, said the inside the cabin of the airplane, it's about the same safety as an indoor space, or maybe even a little better. But for me, it's when people don't going through the lines, it's a little concerning if the airport's crowded going through lines. So I think travel plans should be individualized as well, based on the risk and what you're trying to do. I had a patient whose mother's dying in France, and she has autoimmune disease, Hashimoto's thyroiditis. And so she had a consult with me about that. But, life is about risk benefit ratio. She really wanted to see her mother. So she had an appeal from the consulate and she got a visa to go to say goodbye to her mother. But yet it was, she's one with Hashimoto's autoimmune disease. So I think that's an individual decision as well.
I think it's really individual as well. And I think that, again, if you're going to party or going to be in a big group and you're going to be indoors, I mean, you're definitely at risk regardless of the travel. I think that, a plane that is chock-a-block full and thinking about how people are viewing COVID, I do believe that COVID is a disease. I do believe that people get sick with COVID. And I do believe that you are asymptomatic before you know. So somebody could be on that plane with you and be not wearing a mask or coughing or something else. So keeping your wits about you. And again, I have traveled in the last 9 months, and I've traveled to every state, unfortunately, just oddly enough, that has massive issues with COVID, right? The top 3 states I've been to. And I've been on planes going there. The planes have had relatively few people on it. I've been impressed with my plane rides. And when I go there, my goal is never to be in a big group. I basically go to do the little thing I'm doing, whatever it is. And I'm doing exactly what I do at home, sparing crowded places, never going inside. So I don't really feel like I've been at risk, increased risk via travel. And I've also done prophylaxis. And the treatment and the prophylaxis are a little bit slightly different. There are different doses of things, but the treatment absolutely involves medications that are prescriptions, and there's a whole tier, and there's a sequential mode, which is why you need a physician. And the prophylaxis, generally speaking, or the prevention, only involves supplementation unless you know something specific about your your genetics or your risk factors. So it's very individualized, but if you're traveling and you're a party animal, I don't think anybody that comes to this webinar are party animals, nor are you or I, Dr. Reiki. We're both introverts. But it's just, if you're really careful and you get on a flight that has less people, and we've looked at this, Dr. Reiki, you and I, Delta and JetBlue are better. Americans, is chock-a-block full on the flights that I've heard about. So I think you have to do your due diligence to see what the flight is going to be like. But of course, you'll never know if there's somebody on there with a risk factor for spread.
I think we should lay low for this Christmas holidays, at least in our area in Florida right now. Still limit and distance. Like, we're going to be outside with my family, my extended family.
Mm-hmm. Wow, what a great question. This is a fantastic question. Ivermectin, because they bring up your ivermectin. Now, ivermectin is one piece of a puzzle in the treatment plan that both Dr. Reiki and I believe in, because we've read the research. So the downsides are small, the upside's potentially big. It's a no-brainer, right? And does that mean not to get the vaccine? Again, I think it's a very, very individual question.
It's a good question, though.
It's a great, great point. And that sounds like this person's really thinking, and she believes that she's had issues related to vaccine. And as my friend who vaccines all of his immunodeficient patients in New York says, we can expect Bell's palsy. We can expect frozen shoulder. What do you think? That can happen with any vaccine. I think that's a big deal. When a patient comes to me who has frozen shoulder, they're upset. When a patient comes to me with Bell's palsy from a vaccine, they're upset. So I think that you've got to decide if that's a big deal for you or not, because you don't know if you'll get it.
I think any vaccine decision, it should be discussed with your physician anyway.
100% agreed.
I want to go ahead in the interest of time to address the supply chain, at least in North Central Florida, as far as I understand it today. So what's happening is I tried to get vaccine through my distributor that supplies the medical office, but basically the government has bought up all the vaccines and it's going through kind of a clearinghouse for our state in Florida, of which frontline healthcare workers are top tier along with seniors in assisted living. And so I actually do have a senior who's married to a man in assisted living. He's getting vaccinated. And even within our hospital, not all the people are getting the vaccine, like the ED department, the infectious disease department, and hospitalists, but not even everybody has the opportunity to get vaccine. So you'll be triaged based on what your acuity or need is, based on your risk of COVID complications. And that I'm still asking clarity from. I emailed the Florida Medical Association and the Alachua County Medical Society, as well as all my resources. I haven't heard back in terms of what this means to Gainesville, Florida and North Florida Integrative Medicine. Do you want to tell your patients what you found out up there at Treat Wellness?
I think it's pretty much the same, but I think it's based on your potential complications of COVID if you get it. So I think it's really for those people with immunodeficiency and immunosenescence. That's what I think. Those are the people who are going to have first dibs, and frontline workers.
Take a picture of this, everybody. We're base internists, Dr. O'Neill Smith and myself, and the American College of Physicians is internal medicine. This was actually a pretty good YouTube yesterday. And I'd like you to take a listen to it. At one point, it got a little political. I was a little uncomfortable listening to it, but overall, it was pretty good. I wish I would have delved a little bit more into the science of the vaccines, but it's a good place to start. Also, I think Sanjay Gupta is doing a good job about questions and answers about COVID.
I think the really big thing is if you can, when you're asking yourself the question, take your fear out of it, take your emotion out of it, and imagine that it were someone that you cared about and loved, and what information would you want to gather to help them answer the question. So when you're listening to any of these YouTubes or Gupta or Fauci or anybody, you want to just basically step back, remove the emotional component, and then really think like this: if it were my loved one, forget about you. No, don't say if it were me, because it's a whole different ball game when we do that. But if it were my loved one, how would I gather the information to know that I would give this to somebody who couldn't make that decision that I adore?
Good way to look at it.
Mm.
One last question from Natalia. She wanted to know if we've adjusted our protocols besides at the beginning where we were messaging C, D, zinc, omega. At this point, we've talked about quercetin which is a mast cell stabilizer and antioxidant. We've also talked about NO-Pro, which is actually, or Neo40, which increases nitric oxide, and in certain people, aspirin and high-dose fish oils if you're a clotter. So those are a little bit more individualized.
And then melatonin.
Oh yeah, melatonin's huge. Natalia, look at the webinar that we updated that on December 3rd. 2 webinars ago, we updated our prophylaxis and outpatient management based on Dr. Paul Merrick's not-for-profit group. His protocol is called the iMask Plus protocol. I think we're going to skip the updates in the interest of time, just to realize that there's a lot of COVID up there, but a lot less, not as much death that we've seen. Actually, I think we're managing it better, at least within our practice.
Yeah, for sure. A lot less death. Yep. Wonderful.
We're going to be launching Pursuing Optimal Wellness Masterclass. If you're interested, it'll probably be launched in May or so. We've delayed it so we could really focus on COVID right now, but just email in if you're interested. It's being designed by Dr. Kathleen O'Neill-Smith, who is an Olympic level athlete and was a coach with the national rowing team, former medical director of Tom Brady's place, TB12 Center in Boston. So it's going to be really amazing. This is what we're talking about, really optimizing, fortifying your immune system.
It is my favorite thing in the world to talk about all of this stuff about optimal wellness. And I love, love, love it. And I always have. It's been 40 years since I've been talking about this stuff.
And you're
I know a lot more now than I did then.
You're going to get the benefit of those 40 years. Plus, she's a science teacher, so it's really easy to understand complex science when Dr. O'Neill-Smith talks. And there's already people interested in that. So if you are interested, email in, tell us you're interested, because we have the class about half full already. Okay, next slide. Oh, Sheila, thank you for the thank you. And please don't forget, we're going to take some time off to spend with our family. We're going to be off next Thursday, Christmas Eve, as well as New Year's Eve, 12/31. So we will see you. We made it. We made it to past 2020. 2020, yay. We're going to see you in 2021. Thank you, Emily. You have done awesome.
Love.
And yeah, so for now, be safe, be well, and God bless you all. Thank you so much. Thank you, Dr. Kathleen, for joining us here in Gainesville.
So fun. Thank you for bringing me into your crowd. And all of you, Merry Christmas, Happy New Year, and Merry every day.
Bye-bye, everybody. Bye-bye.
Bye.
Awesome. And now it is time for our books and our supplements. It's going to be the same as the last 2 weeks have been. So if you need to hop off, that's perfectly fine. And as always, they will be available on Facebook Live and YouTube after to view. As always mentioned, we have our Kick COVID-19 to the Curb guidebook. We are still doing our December special. So if you purchase the guidebook in either ebook or paperback form, you can take 20% off of vitamin C and zinc. You can purchase it on our website. You can buy it on Google, Amazon, Kindle, Barnes & Noble, anywhere that you find easier to buy for yourself. You're welcome to do that. And then, as mentioned before, we now have the audiobook available on Audible. And again, make sure you go ahead and send us an email to FIRRIMupDoctors@gmail.com if you want to view Audible for free. This is only, again, if you do not already have an Audible account. Unfortunately, they won't let you do a free trial in the middle of a purchased trial. Or purchased account, sorry. So if you would like to have the free version, just go ahead and send us an email and we will go ahead and send that link out to you all. As some of you mentioned, we still have the Ageless Triad going, which is the curcumin, the vitamin C, and the glutathione. These are all great together, mixed together. And the code for 10% off is going to be FIRRIMup Ageless. Again, these are good until the last day of December. So make sure if you want to get these, you go ahead and grab them now. Next, we have our vitamin D, which is going to be both liquid and pill form. We have the micellized over here on our left. And then we also have the pill version in 2000 IU and 5000 IU. So whatever your preference is, as long as it's one of these three listed, you can get 10% off using the code FIRRIMUPVITD, VITD. Again, All these are good until the last day of December. Next, we have your Prp Zinc and Quercetin. These codes are each going to be separate, but your PRP is going to be FIRRIMup PRP. Your Zinc is going to be FIRRIMup Zinc. And then lastly, the Quercetin is going to be FIRRIMup Q. And make sure you add each of these into your cart as you add the actual supplement. And then use these codes at the very end and you'll get 10% off. Then we have the omegas. We have 10% off for a regular omega, which is going to be FIRRIMup Omega. And then if you are a vegan, we have the algae omega, and that code is going to be FIRRIMup Algae. And then we have the nitric oxide pack. And so this is from Dr. Nathan Bryan's video. So if you want to go back and listen more on that, go find it on our Facebook or YouTube page with Dr. Nathan Bryan. And this is going to include NO indicator strips. It's going to have NO tablets and then NO dissolvable lozenges. These are not a pack. You can get them each separate, but go ahead and plug in the code FIRRIMup Human if you're looking for any of these. And then lastly, we have the melatonin, which is great. They just talked about at the end of the webinar today. And we have it both in liquid and lozenge form. So either of these can get 10% off using the code FIRRIMUPSLEEP. And then as always, we have Dr. Iki's Fine Tune Your Hormone Symphony. This is her guidebook to basically understanding your hormones. It is available on FIRRIMUPDoctors.com and also Amazon. And lastly, we have the Fascia Function and Medical Applications textbook, which we have a few left in the office. You can do curbside pickup for $55. And if you would like to do that, you can send us an email at nfimgmv@gmail.com. It is also available on our FIRRIMUPDoctors.com website, as well as Amazon. Make sure if you're trying to get that discount code, which is listed below, it is only good until the very last day of December. So if you are trying to get a discount, go ahead and make sure you purchase before that last day. But the code will be SCI20. And once more, it can only be used on our website. Unfortunately, Amazon will not accept the code. And that is all that I have for everyone today. It is going to be a long 2 weeks without seeing you guys, but we will be back in January with more information, more updates, and ready to kick out 2021 stronger than ever. And I hope everyone has a wonderful holiday, no matter what you're celebrating, and a very happy new year. Bye, guys.
We're so glad you joined us today.
We hope we've given you the tools to take control of your health.
For more good medicine and information about any treatments, supplements, and resources discussed today, please visit us at www.FIRRIMUPDoctors.com. That's FIRRIM
And wherever you're listening from, remember to like us on Facebook and subscribe to our YouTube and podcast channels so you don't miss out. The information provided is not a substitute for professional medical advice. This should not be used to diagnose, treat, or manage health problems without consultation. If you do experience any of the symptoms discussed today, please contact your nearest healthcare professional.